always curious, is just by a show of hands, do you guys mind telling me how many of you have heard of Metro Crisis Services before? Oh, wow. Well, I'm going to go home. No. So I'm going to give you just a little bit of information about Metro Crisis Services and where we came from. So some of that might be a repeat for some of you. But then to focus a little bit more specifically about how we can be helpful for medical practices, or how we think we can be helpful for medical practices. So for those of you who don't know, Metro Crisis Services, as far as our call center goes, has been around for about 3 years. And we were initially formed from a group of stakeholders throughout the Denver metro area, really to try to address a gap in services for people with behavioral health crises. And you know what the community has identified as a problem is that many people have behavioral health needs and just not a lot of easy access to resources, especially if you have an urgent need. 911 gets called frequently. That's really been our community crisis plan, for better or for worse. Going to an emergency department because it's 2 o'clock in the morning and I need something and don't know where else to go. Or kind of sitting at home and figuring out what to do. And so there were many parts of what was known as the triage project back then, but the crisis line piece is what I'm here to talk about. So as far as Metro Crisis goes, there's a couple on the right. Those are some of our billboards that it's been a while since they've been out. But I also put this Lifeline, Suicide Prevention Lifeline logo up there. There's a lot of folks that are familiar with the Suicide Prevention Lifeline, and we are actually the local provider for that. So if you hand out Metro Crisis's number, or if you hand out this number, the same people are going to answer the phone. So how that works, there are actually 2 different providers in the state of Colorado that answer that line, but anyone that is calling from a 303 or 720 number will ring to us. Any other area code will ring to a call center in Pueblo, just as an FYI. So that's us there. We have a couple of different roles in the community. Like I said, that there's the National Suicide Prevention Lifeline. We also have some fee-for-service contracts where we answer phones for other companies, mental health centers. We work very closely with Colorado Access, answer their member crisis line 24/7, as well as answer the calls off hours. So Colorado Access is probably one of our strongest partners in some of the things that we do around the community. So why phone intervention? Why do we focus on that? What's our goal when we have folks on the phone? Obviously, it's easy. The only prerequisite you need to use our services is you have to have a phone, and it doesn't have to be your phone. There's no time limits. There's no appointment scheduling. You can be sitting in your boxers on the couch with the Broncos game on pause, give us a call. You can be in the car on the way home, wherever you need to be, break from work, and call us. It's immediate access. So in the moment, during a crisis, or I have time to actually deal with my crisis right now, you can pick up the phone and call. It's free. That makes it easy. So this convenience, what we really feel with a crisis line is it allows a place for an intervention to happen that might otherwise have never happened. I mean, we know trying to get into services, there's wait lists all over the place. You're leaving voicemails, they call you back, you leave another voicemail. There's a process for folks to get into care. Certainly for folks who need sliding fee scale resources, have transportation problems. I just got this job, how do I take off work so I can go see my provider? There's a lot of obstacles and barriers for people to getting into care. One thing about a telephonic intervention is it really breaks down some of those barriers pretty easily for folks so that we can at least get our foot in the door and start making a plan for an intervention. So, as far as who answers the phone, a little bit about us is that there are different crisis lines throughout the state of Colorado and throughout the country, actually. One of the things that's unique about Metro Crisis Services is who answers our phone. All of our staff are minimum master's level staff, and right now I think we're at about 80% of our staff are licensed, and about a third of our staff are CACs as well. So we really strive to have that professional available on the phone 24/7 versus other common models which might be volunteer run and things like that. So we do have a translation service that we use. We don't have Spanish speakers that are available 24/7 in our office. It's always a goal of ours, but as you guys probably know, that's a challenge. But there's a lot of other languages that are spoken in our state, there's no question. So we do work with a telephonic translation service. So if you have anyone that's interested and English isn't their primary language, assure them that they can call. And we can, if they can communicate enough to just tell us what language it is, we can conference in a translation service and complete that call. So we always have supervisors on call or on site, and we have a pretty rigorous training program for our clinicians. What our initial training program is for our crisis clinicians is really a focus on, obviously, crisis work. But our niche in that is providing crisis services on the phone, which is a really kind of different animal than a face-to-face crisis. We're often working and making really quick decisions with limited information, and we don't have any ability to use our nonverbal communication. Are you guys familiar with some of the studies about how much we say our communication is verbal versus nonverbal? Somebody throw out some numbers or percentages. 80%, 90%, upwards of 93%. I've heard often is communication that's nonverbal. So when I bring clinicians in and start, I said, okay, I'm going to put you on the phone. I'm going to take away the vast majority of your ability to communicate, and I'm going to ask you to make really important decisions in a really quick moment. And they're like, okay. And they're either like really into it, or it's like, well, maybe not. So our focus of our training and our ongoing training is really to hone those skills so that when folks are calling in, they're getting someone who, one, isn't going to get rattled with whatever they get, but someone who really has spent a lot of time thinking about how to manage a crisis over the phone with little kind of resources at your disposal. Okay? I kind of skipped over the 40% of callers get follow-ups from us because I think that is an important part of the service that we provide. Anybody can call in to our center for any reason. Behavioral health, well, not even behavioral health related. We have people calling about all kinds of things. We try to be as helpful as we can. But the piece that is the part B of that is that we have a pretty robust follow-up program with our folks so that it's not necessarily a one-time call and you're out. If we give resources, we try to follow up with those people. Did they work? Did you get through? Do you need more? Certainly if there's any safety issues, there's quite a rigorous protocol for following up with those folks. So that's a piece of our volume. We've been looking at some of our numbers, and probably about 50% of the people that call us are already in treatment somewhere with a behavioral health provider. We were looking at some of our numbers, and our referrals weren't nearly as high as we thought they should be, and so we've been digging into that, and the reason is because a lot of people who are calling us already have treatment providers. So those folks are okay to call us too, and in those situations, our goal is really to collaborate with those providers that are providing care. We're never looking to step on anybody's toes or to interfere with any treatment that might be going on somewhere else. So when we identify someone who's going to be utilizing us as a resource, one of our first calls is so how do we get a release of information? How can we become part of a support team and not try to be undoing everything that happened in therapy this morning now that you're calling us at 2 o'clock tonight in the morning or whatever. Okay. So how do we help callers? So certainly there's that in the immediate crisis support and in the moment consultation. I've said many times throughout the last 3 years that I wish that the word crisis wasn't actually in our name, because I think we know the goal with crisis, and certainly in suicide prevention, is to try to get upstream more with people. You don't have to be in crisis to seek support. You don't have to be in crisis to call. But it's in our name, so there you go. But we get a lot of people calling saying, well, I'm not really in crisis. Is it okay if I call? And the answer is yes. If people can call us before they're in crisis, great. That's all of our goals. So if you have people or you're talking with people about our line, don't think that we need to be like totally suicidal before it's okay to call. We're a resource, a behavioral health resource for any part along that continuum. So what will you get when you call, as if you're calling for yourself? Certainly, every call gets a safety screen. We're going to be asking about sort of safety issues, and we're going to be asking about substance use. Those are just kind of part of our deal. So, but at that point, then that's really going to sort of dictate where a clinician goes with people. There are some people that call our line and say, "Look, I know I need behavioral health help. I don't know where to start. I got this insurance, or I have Medicaid, or I don't, or whatever. Just give me some numbers to call. That's all I want." It's fine. Those calls are easy. We have other calls from folks that are just, I don't know what I want, I'm a mess, help me. And so that's a little bit more of an in-depth assessment to see if there's safety issues involved, are there substance use issues involved, what kind of relationship issues, past history, all those kinds of things. So folks will get a variety of kind of assessments that way. I don't think, if you ask anybody that called, I don't think that they would say that they feel, we're not a scripted line. So it's not an assessment tool of what's the answer to this, what's the answer to that. And the other thing, that is really a core part of our training with our staff, is we're building rapport the entire time we have someone on the phone. Our goal is not to batter them with questions, but it's still our responsibility to do a good assessment. So we really train on that line. We provide, like I said, referrals, linkages, ongoing support while other services are put in place. It's often that we get people appointments, or we can help facilitate appointments to different places, but it's in 8 weeks. It's like, okay, so now what do I do between now and then? Our goal is certainly to focus on the crisis and in the moment and that linkage, but we will also provide that supportive care of that person until they can get hooked up with those services. Because between now and 8 weeks, a lot can change. One thing that often changes is, well, my crisis is over, so I don't need to keep that appointment, so I'm not going to show up until like 3 months from now. Now I'm in another crisis, and I'm right back where I started. So sometimes having us, and I affectionately refer to it as nagging people, to just say, hey, so how did today go? It's been a week since we've talked to you. You still got that appointment. It's scheduled. Great. Do you have any transportation problems? Anything getting in the way? So we can continue to follow up with people and provide that support. As we do that, even though a lot of times people aren't necessarily all that excited about engaging with us again, if that crisis spikes in that time frame, they're more likely to call us back so that we can continue to support until they get something more stable in their lives. I'm going to mention our resource directory as well. If you go to our website, we have a resource directory. There's about 3,500 resources on there now. Most are specific to behavioral health, but you'll find some ancillary needs on there too, as far as food banks and things like that, shelters. And that's a resource that's available to anyone in the community, free through our website. Just go to Metro Crisis Services. We'll come right up. So if you're ever in your office or you want to refer someone to that, you're just looking for a quick referral, that's available for you. I always put this disclaimer out there that I think we're all really spoiled by Google these days, because like Google reads our mind and just knows exactly what we're looking for. This isn't Google, this is a database. So if you have any issues finding what you're looking for, you know there should be something in there, maybe I'm not typing the right thing or whatever, please just call us, because our clinicians work in this every single day and they can weed through it really quickly. And it's totally fine just to call to say, I'm looking for a number, just give it to me real quick. Okay, great. And you're off the phone. So don't feel like you have to engage in a 20-minute assessment about whether you're safe or not. We can help you with those resources too. So how can we help with assisting medical providers? Obviously you guys are here because you have concerns about behavioral health services and how you support your patients. And I'm well aware that clinics across the spectrum have different levels of behavioral health support in their practices as well. So we certainly don't intend to be the answer to everything for everyone, but we do want you all to know that we are a resource for your practices. So what do I mean by that? So patients in your office can present with certainly a variety of different needs, and you may or may not have the ability to make good referrals, to do any research about what this person might need, or maybe you do give them a great referral, but you have no idea if they actually follow up, or if they're going to make that call, or it's someone that you can tell they're not doing so well, they're looking a little worse last time they were here, I'm really concerned about this person. So how do you feel like you can keep your arms wrapped around that person knowing that you got a waiting room full of people? So this is how we can try to be a resource to sort of handhold that person for you, to know that if you make a referral to us, regardless of what their insurance is, regardless of where they live, or really what their behavioral health need is, we can help facilitate with some of those services. So again, we can assist with making referrals. We cannot schedule appointments directly for people. We don't have access to any provider's appointment books, but we certainly can help people facilitate that, make some calls on their behalf if that's what's needed, whatever it takes to kind of get that person engaged. Again, we can perform those assessments on the phone. So if it's a patient that there's something going on, I'm not quite sure what this is, we can certainly be an additional kind of clinical frontal lobe to talk with that person and help with a differential diagnosis, or try to figure out where would be a good place for them to start in the behavioral health world. Certainly, suicide assessments and safety planning is kind of the core of what we do. And I'll get into some examples of how this works, which might be a little more clear. But certainly if you have someone in your office and you have some safety concerns, it might not be really obvious as far as, is this person really serious? Is this person just kind of, for the last 6 months, kind of been baseline suicidal, or is this someone I need to do something with right now? And I've got 15 minutes with this person. How do I manage that? So there's certainly different ways that we've worked with medical practices in the past. If that's being able to move that person to another room so that they have a phone, call right away and get us on the phone so we know that there's that connection made. We can work with that person on the phone right then and there to kind of make that plan. So that if we're talking with that person and we have a recommendation of, she really needs to not go home tonight. We need to do something a little more intensive and figure out how to get her to the hospital tonight versus, yeah, she's having a rough day today, this, and this happened, but we've got a really good plan together for tonight. We're going to follow up with her when she gets home from your office. She said she needed about an hour to go home and pick up the kids, and she'll be home after she makes dinner, so we'll call her then. So we can do some of those things to kind of patch that piece together so that as a medical provider, you can move on and really focus on those medical pieces. The other thing that we can help with is once those referrals are made, if that's the appropriate place, so we've connected with your patient and we're gonna work on trying to get them an appointment somewhere. So we can then, on your behalf, have that conversation with a behavioral health partner. Well, this is who the medical provider is, and can we facilitate getting that ROI together so that everybody gets connected then around that same person. So those are things that we can kind of do on the back end to sort of help support those situations. Okay. So real quick, just a couple of examples. I'll let you read through this, but these are actually real scenarios that we had with some of our medical practices. One was this patient who showed up at her appointment, and she was very articulate about her suicidal plan and her desire, and really created quite a ruckus in her practice. She was really upset, and so the end result of it was they did end up giving us a call, and so we were able to spend some time with this person on the phone and really kind of get a good plan in place to realize that this wasn't necessarily an acute crisis as it appeared, but more of kind of a chronic crisis. And so we were able to kind of help calm the situation down, give the nurses some support to get this woman sort of to her next step where we were able to follow up with her. But the great part about that too is that whole experience kind of brought to light in this clinic that none of the nurses or staff felt really comfortable in what to do as soon as somebody says this. So we were able to have some follow up with the staff too about so what might be, kind of the order of things we go through, how might we handle this next time, those types of things. And then this was just another kind of example of someone who the medical provider really knew that this person was suffering from depression, had been for a while, makes referrals over and over again. Every time they see them, have you called? Well, no, there's this, that, and the other thing, and then this and that and the other thing, and so I haven't really been able to get to it. So it really just made a simple referral to us to say, hey, are you familiar with this resource? So then we were able to kind of get our arms around this person, continue that follow-up, and actually facilitated an appointment scheduling, because there was really just some roadblocks getting in her way that she couldn't problem solve through, which was really about how do I even get there? I can't physically get myself there. So after having some conversations with her, that was really where we were, and once we removed that barrier, it became really easy for her. So those are just a couple of examples of how we might be able to help in those kinds of situations.